Good evening, everyone. At the outset, I thank Indian Arthroscopic Society for giving me this opportunity to present a video demonstration of arthroscopic fixation of both anterior and posterior tibial spine avulsion fracture for their IAS YouTube channel. So my patient is a 54-year-old lady who presented with who presented with a history of fall at home and presented to us after 10 days of injury with pain, swelling, inability to weight bear, and instability. On examination, there was mild effusion, anterior and posterior joint line tenderness, and assessing the instability was painful in this acute scenario. So, and her range of movement was only 5 to 70 degrees, and it was painful, and there was no distal neurovascular deficit. So as a routine, we take a standard anteroposterior and lateral view of X-ray, and you can see that there is a anterior tibial avulsion fracture, which is very clearly seen on the lateral view. You are not sure about the PCL avulsion here, but if you see carefully on the anteroposterior view, there is a small fracture line here, which sometimes gives us a hint of such an injury. So when you are in doubt, it's always better you get a CT and MRI done further to assess the fracture pattern and anatomy. And also it is MRI is useful to see the status of the ligament and also both the cruciates and the menisci and any other associated injuries which can be addressed when you are dealing this fracture pattern. So having as you can identify, you see that there is a fracture anterior tibial spine which is avulsed with intact ACL here. There is a fracture line going down, lifting the posterior tibial spine, but the PCL seems to be intact here. So definitely there is few millimeters of gap here, which definitely patient will be benefited by doing a fixation procedure. So we decided to take up for an arthroscopic fixation for this patient, and patient was put up in a supine position. We usually have a bolster saline bottle at 90 degrees and 100 degrees flexion, and then patient was taken up in epispinal. Under anesthesia, you can see that there is a posterior tibial sag present. There is a good posterior drawer and anterior drawer instability present for this patient. So this we do take a standard arthroscopic portals, the anterolateral, anteromedial. Also we take an accessory anteromedial portal and take posteromedial, superior and inferior posteromedial portal. So you clear the hemarthrosis by joint lavage, address the associated intra-articular pathology. It is very important you clear the bed and of the crater by removing the interposed soft tissue, and then fix PCL first and then ACL. So this slides give us what we are dealing here. So the anterior tibial spine avulsion is which involves the anterior medial and the posterolateral bundle, and here it is also sometimes may be associated with the anterior horn of the either medial or lateral meniscus, which can be addressed by the suture bridge technique. The most important point here is the intermeniscal ligament, which usually forms the culprit to get an anatomical reduction. And then you notice that a PCL has a very broad insertion on the tibial side. So it is very important you get your endobutton right in the bony fragment here, which may differ when you are doing a reconstruction, which you come quite lower down. So we are weaving through the anterolateral portal and working through the anteromedial portal as the routine technique. You can see the ACL is lax here, and there is a crater. The medial meniscus, the body and the posterior horn was intact, so there was no any tear demonstrated. but there was a degenerative tear with the cleavage on the lateral meniscus. So we debrided the tear, and then we further probed it to its stability, and we found it to be stable, and so we left it alone. Now we come to our crater, the anterior tibial spine. So you make clear the crater with the whatever interposing soft tissue here. So in our case, the meniscal, there was no involvement of any antihorn of either meniscus. So it was purely a ACL avulsion. So we removed the interposing soft tissue here, and then we go ahead with making a transseptal portal. So which will help us in securing the posteromedial portal. So we know posteromedial portal, we have to palpate the soft tissue triangle between the femoral and tibial condyle on the posteromedial aspect, and then secure the portal with a spinal needle, Singer rod, and then with a cannula. Then we just pass a post periosteum elevator, PCL elevator, just to make sure the depth where we have to go, so that we can even take an additional posteromedial inferior portal, so which can be used as a working portal, and the superior can be used as a weaving portal. So now we have secured our posteromedial portals, and we can go ahead with the fixing of the posterior medial PCL avulsion fragment. So we take a fiber wire, we take a bite in the PCL, and then we throw a sliding knot with several half stitches, which is well demonstrated by Dinsha Padiwala technique, where he takes a couple, two fiber wire and throws several half stitches, and which he uses them as a fixation method. So here now you come with your bead pin. So we did not go the standard 15 mm depth which we take for the reconstruction. So we come up, and then we take a bead pin into the fragment, through the fragment of the PCL. So you confirm that in the ACL. So you can see that your wire is quite up. So you pass a nitinol wire through this. We don't do any over rimming of 4.5. So we push the fiber wire which we had taken a bite in the PCL, and pull it out on the posteromedial cannula, through the posteromedial cannula. Here we do an additional thing. We take a fiber tape loaded on the endo button and pass it through the nitinol wire, and separately the fiber wire as well, and pull it anteriorly on the tibial condyle. So now you can see that this is the endo button with a fiber tape, and anteriorly you have a you can see here we have fiber tape as well as fiber wire, which we load it over a free endo button, and then tie it over the posterior over the anterior tibial medial condyle, and in around 70 to 80 degrees of flexion. So you can see the PCL gets taut after this fixation. So now we go ahead with the fixing of the anterior tibial spine avulsion fracture. Similarly, we take a fiber wire on the through the anteromedial bundle, and then we pass a sliding knot, which we did similarly for the PCL, and throw several half inches for this fragment, and then we take an additional bite of a fiber tape, which we did similarly for PCL, but we did not take a bite in the PCL. Here we have to take a bite in the posteromedial, posterolateral ligament, and then you put a lasso here rather than putting a sliding knot. We take a lasso. So you have fiber tape with lasso stitch, and you have a fiber wire with a sliding knot. Then we take a bead pin on the anteromedial part of the crater, and you pass a nitinol wire through that, and retrieve the lateral limb of a fiber tape as well as fiber wire through this portal. So anteromedial shuttles the lateral limb of fiber tape as well as the fiber wire. You repeat the similar procedure on the antero lateral aspect, and you take the medial limb of the fiber tape as well as the fiber wire through that. So this brings you a crisscross pattern of the sutures, which will be fixed on a bony bridge on the anteromedial aspects. So you can see how taut the ACL has become now, as well as the PCL after this fixation. So to repeat the anterior tibial fixation here, we take a fiber wire with a sliding knot. We take a fiber tape to the posterolateral and put a lasso and take a small tunnel, make a small tunnel on the anteromedial of the crater aspect of the crater and shuttle the lateral limbs of fiber tape and fiber wire, and then similarly make a tunnel on the anterolateral aspect and shuttle the medial limb and suture it over the bony bridge. And we see that both the ligaments are very quite stable. So here you can see this is the endo button on the CM, very well nicely seating on the posterior aspect of the crater, which is fixed on the anterior over the free endo button, and the anterior tibial spine is well seated and it is fixed with over the bony bridge here, so you don't have to use any implant, and you can check the stability here after the fixation. It is quite stable. So this is the stability you achieve here. So we protect our patient with a long knee brace in extension for 4 weeks. We mobilize them non-weight bearing, and then ask them to do isometric strengthening exercises and gentle ROM exercises. And after 4 weeks we allow them partial weight bearing and full weight bearing after 6 weeks, and then do a strengthening exercises and allow to do them their routine works after 3 months, and the return to sports is ideally after 6 to 9 months. So to summarize, simultaneous ACL and PCL avulsion injury is a very rare injury, but appropriate management by arthroscopic technique have an excellent outcome. Thank you. Thank you, one and all.